So starting with my first case, a 5-month-old male child diagnosed elsewhere as stage 5 ROP with a gestational age of 28 weeks, birth weight 1.5 kg, history of NICU stay for 15 days and oxygenation for 12 days, and a history of phototherapy for 12 days. The child was poorly fixating in light with no following movements. Retinoscopy in the right eye showed dull reflex and the left eye had a clear reflex. Both eyes cornea were clear, lens were clear. On fundus examination, the right eye media was very hazy because of the presence of the retrolental fibrous tissue in the left eye, but we could see a falciform fold extending from the disc to the and attaching anteriorly to the nasal retrolental fiber. So the patient was advised for ultrasound. Right on the ultrasound in the right eye showed posterior closed funnel RD with the deep troughs were seen. And in the left eye, variable reflective membranous echo was seen, extending from the ONH to the nasal posterior capsule of the lens. So the patient was diagnosed as a stage 5 ROP sequelae, and both eyes EUA with right eye lensectomy and vitrectomy was planned with very guarded visual prognosis. And for the left eye, no intervention was planned. So on examination under anesthesia, both eyes cornea were clear, and in the right, IOP was 6 and 8 mm Hg respectively. Horizontal and vertical corneal diameters were 10 and 9.5, but in the right eye, we could see a retrolental fiber with some clear areas seen inferiorly and temporally. In the left eye, we could see a clear glow and a small retrolental fibrous tissue was seen attaching to the nasal part of the posterior capsule of the lens. So on these are the RETCAM images. Yeah, in the right eye, the retina was completely lifted up and attached to the posterior capsule of the lens. And in the
Anjali, may I just interrupt? Go back to the first picture. Since they have got the mic, postgraduates, I'll just ask them, what is the differential of a white reflex in a child?
This one.
So, retinoblastoma.
Okay. One you have told. 2 more, that's all.
Sir, congenital cataract.
Okay, very good. White reflex, congenital cataract, retinoblastoma. Anything else? One more.
Congenital glaucoma.
Congenital glaucoma is not really a differential diagnosis of a white reflex. You can get white striae or scars.
So PHPV.
Good. So that's another one. Very good. Everything is always, you can always remember as a tumor, inflammation, infection, developmental and trauma. Under this category you can fit anything. So think that way, you'll be able to. So ROP is congenital or is it secondary? Yeah, so ROP is secondary. PHPV is congenital or secondary? Bold and say, congenital is anything which is before birth or at birth, not following birth. So what is it? PHPV is congenital or?
The congenital.
Okay, congenital, correct. Cataract you already said is congenital. So ROP is not congenital. Retinoblastoma?
Not congenital.
Not truly. Okay, you can have intrauterine retinoblastoma.
Okay.
So when the child is born, they can be born with a full-blown tumor, which gives you right reflex. So that's a very important differential diagnosis. So, but the white reflex is behind the lens, not involving the lens. So this is a differential diagnosis of a white reflex because of a tissue which is filling up the eye behind the lens.
Yeah.
So retinoblastoma is something which you should be aware of in a child born with a white reflex.
Okay.
Other than PHPV, and this is born, the child is premature, it's not born with a white reflex. It develops a white reflex over a period of time. Around 2 to 3 months it takes for the white reflex to develop if the disease is untreated. Yeah, how you can go on?
Yeah, so after lensectomy and vitrectomy in the right eye on post-operative day 1, the patient developed dispersed heme. So again, an ultrasound was repeated. Now the ultrasound showed a narrow funnel RD, and the troughs which was seen previously, they decreased. So the patient was explained poor prognosis for both the eyes and is still in.
So it should be the parent. Patient is too young to understand.
Sir? Yeah, yes, sir. The parents were explained the poor prognosis for both the eyes, and the child is still in constant follow-up. Coming on to my second case, this was a 1 month male child diagnosed elsewhere as zone 2 stage 3 plus disease. Gestational age was 32 weeks, birth weight 1.8 kg, history of NICU admission for 29 days, on ventilator for 9 days, and supplemental oxygen was given for 20 days. So retinoscopic reflex was clear in both the eyes. Lens were clear, pupils were well dilating. So on fundus examination, in zone 2, there was a ridge with the neovascular proliferation extending inside the vitreous. So zone 2 stage 3 with plus disease was diagnosed. So the child was planned for laser to the avascular retina in both the eyes. Yeah. So 1 week post laser, the plus disease started decreasing, but the ridge remained as it is. And 2 weeks post laser, the plus disease decreased significantly. The stage regressed by 1 stage in the right eye, but the left eye showed persistent ridge, and traction was suspected to be developing. 3 weeks post laser, there were well established laser marks, and but the persistent ridge with the suspected traction in the left eye was still there. So the patient was planned for left eye lens sparing vitrectomy under general anesthesia. So on examination under anesthesia, we can see that the right eye was well lasered with the flattened ridge in the periphery. The fibrous tissue was noted in the periphery, but it did not seem to cause any traction. The disc and macula were okay.
The ridge has subsided, so it's...
How do you know? You haven't got a picture of it?
No, that's what she said, sir.
He said. Again I said, what you see on the slide, that you should tell. Forget about what's the past history. You tell me whether it is... The patient has come to you first time. Tell me whether it's active, inactive. It's either active or inactive.
The laser scars are a bit away from the fibrosis or the ridge. So maybe it was not adequately lasered, or it is regressed.
You're being a lawyer, man. You tell correctly. If you have information, you want information, more information, you will get more information. So you should tell. I think I don't have enough information to tell, or I can't see properly. I would like to see a better picture that tells me more about what is anterior to the ridge. All those things you can tell. But what is the main thing that you can see? There's no plus. Right? Ridge is white, red, pink,
White.
grey,
Whitish.
white. So what does white mean?
It's fibro.
White means it's organized. The right word to use is organized. Right? So it's organized. So white means it's organized, which means it doesn't have any blood vessels. It is organized now. It has reached the final phase of remodeling. Okay, go to the next.
So the vessels posterior are still not fully normal. There's still mild tortuosity is there, sir.
Good point, but I will neglect that right now because it's single slide.
Hello. Sir, in that slide, we can see 2 ridges. Can you
Slide.
Are there 2 ridges, sir? Is it so that the area up to which the laser marks are there, it was the original ridge and now a new ridge has formed or something like that?
No, it's a 3-dimensional structure. You are seeing something which is 3-dimensional.
And
Don't assume that ridge is just a flat line. It's got a 3-dimensional structure.
so are there two rows of ridge?
It's not 2 rows of ridge. The ridge has got a 3-dimensional structure. You're just seeing 2 parts of it. That's it. Planes of it. In between, you're not seeing something, but there must be a bridge of tissue there. It's not reflective.
Yeah, next.
Yeah. So you see this,
This is the right eye.
and do you see vessels
And
beyond
this is
it?
the...
Go back. We're still not finished. You see these vessels, and it's actually very faint, but there are vessels beyond that. Okay? So vessels are not jumping this ridge and going. The vessels are going from the base of the ridge anteriorly. Okay? The ones which is jumping and going are not retinal vessels. They are new vessels. The vessels which are going through the ridge or beyond the ridge are normal retinal vessels. All right. So we have to differentiate between the two. This is just a fibrous tissue floating over the surface of the retina. There is no PVD, okay? Doesn't happen. So this is just normal organization in the vitreous above that ridge. Some time back, before the laser, there were vessels there. Now the vessels have regressed. But because there was so much exudation and vessels were there, then ultimately they'll organize. Okay? Where there are vessels, there are going to be organization. Fibrous tissue will come. Vessels cannot float. Standard physiology is vessels cannot float. They need an extracellular matrix, which is collagen. So collagen is secreted. Once the vessels are dead, collagen is also over. It will reorganize or it will involute completely.
In the left eye, the periphery were well lasered and pre-retinal fibrous tissue was noted lying on the retina, but no traction was noted.
Okay, again we'll take a call. Not a lawyer. We'll ask somebody who's going to say yes or no. Simple yes or no. Do you see TRD or do you don't see TRD? Or you don't see TRD? What is your gut feeling?
Looks like there is no traction, sir.
Good. She says she's no traction. Anybody wants to differ?
It looks slightly elevated.
It looks slightly elevated. This tissue is elevated, no doubt about it.
Yeah, but it
There's
looks
another
like
tissue
the
inside, no?
retina is also slightly elevated.
Slightly elevated. Okay. So this is a two-dimensional picture. Obviously, when you're looking at the child, you'll be able to see much better and gauge it as either elevated or not elevated. So in this two-dimensional picture, it's very difficult to say it's elevated or not elevated. The retina below this tissue. But one important point is you can see the color of the tissue, and you can see the vessels behind it. Okay, the vessels are elevated or they're tortuous, like Dr. VJP was alluding to the previous eye. Okay, so that will give you an idea whether it is elevated or not elevated, or it's pulled. Remember one thing, it's not necessary that you should always have a tractional retinal detachment. You can have a tractional schisis also. The retina can be split into layer behind the ridge. That's also a point. It's not always TRD. There can be tractional schisis as well, which can extend all the way up to the fovea. It's sometimes very difficult to see, and that's where the OCT can sometimes help you. You can go ahead.
Yes, sir. So the findings were confirmed with the OCT, SD OCT handheld. In the right eye, the macula and fovea was the macula and the optic disc were intact with the minimal or no fibrous tissue visible in pre-retinal. This is the periphery of the right eye. No pre-retinal fibrous tissue causing any traction was seen. In the left eye, the disc and macula appeared normal, and in the periphery, we could see a pre-retinal fibrous tissue which was just lying over the retina, but it was not causing any traction. Hence, the decision to do the surgery was deferred, and the baby is kept in close follow-up. Now, coming on to my third case, 28 days baby boy, diagnosed elsewhere as aggressive ROP, gestational age of 31 plus 2 weeks, birth weight 1.79 kg, history of birth distress and NICU admission for 1 week, CPAP given for 2 days, and history of phototherapy. Retinoscopic reflex in both eyes were clear, and pupils were well dilating. On fundus examination, showed severe dilation and tortuosity of the blood vessel in the posterior pole, with the retinal heme seen inferiorly in both the eyes, along with a ridge with the vascularization into the vitreous in zone 1. Hence, a diagnosis of zone 1 ROP stage 3 with plus disease was made. So the baby was planned for laser to the avascular retina, but unfortunately during the laser the baby developed apneic spell and was referred to pediatrician after the stabilization of the vitals. The baby also developed late onset sepsis and anemia, treated with blood transfusion and antibiotics. So 5 days post laser, the fundus picture appeared quite similar. There was no significant regression of the plus disease or the stage. So in this picture, we can see the ridge with the proliferation into the vitreous in the zone 1, significantly dilated blood vessels, and retinal heme seen inferiorly. These were the laser burns, but significant space was seen between the ridge and the burn marks because the laser could not be completed because of the apneic spell in the baby.
So this is a loop vessel, which is abnormal. So anything between the loop is usually avascular. So this needs more laser. Okay. This is what it's showing is it's a collateral. I mean, it's not a collateral, but what it's showing is a shunt vessel. Vessels are going to a particular area and then coming back. They're not, because there are no capillaries within it. So they're just shunting. Blood is just going and shunting. There's no capillary developed here. This is still an avascular area. So this also needs treatment. All right. Anjali, if you have seen so much of now regression patterns, what are these lesions? These tiny lesions there. Not this. This we know this is extraretinal proliferation, which signifies stage 3. What is this?
So this white fibrous
Yeah.
islands you're saying. So these are the islands of condensation of vitreous.
What are they?
So vitreous condensation.
Correct. They're vitreous condensation, but what are they condensing on?
On the avascular junction of the vascular and avascular zone, sir.
Anybody can guess? Speak into the mic. Yeah.
Extraretinal fibrovascular proliferation is called as popcorn.
Yeah, so these are kind of popcorn lesions. And many of these popcorn lesions, which when they coalesce into a network, then you see a large tissue like this. So in the very old publications, you will hear something called rear guard and vanguard. So the rear guard is where they were thinking that if we do laser behind the ridge, it may help in regressing the ridge, which you don't do nowadays. Okay. So that's only for the last resort if nothing is happening to the new vessel disease. So these are nothing but new vessels actually, but they're very tiny. They're just like, you can call it microaneurysms, but not new vessels. So they're very tiny vessels, and the vitreous is condensing on that, so popcorns. So this sign, if you see, disease is extraretinal neovascularization is there. Okay. If you see hemorrhages, that means it is in the stage 3 plus, stage 3. If you see hemorrhages, if you see these lesions behind the ridge, even if you don't see this, then you should assume that this is a stage which will need laser. If there is no plus, you observe, but closely observe. But if there is plus, you treat straight away. Closely observe means it could be once 3 days later, but not 2 weeks. Okay? You're not going to wait for 2 weeks because you have seen this now, and then you don't waste time. You see them earlier because they can rapidly change into a plus disease. All right. I just wanted to show you this. This is called the loop. So a lot of you are going and seeing ROP. So this loop vessel is abnormal, which means the tissue within it is avascular. So you have to treat this. And this we have done after the child is stabilized.
So
Exactly. This is also the same thing.
same picture.
See hemorrhages. You see those popcorns are not very clearly seen, but you can see the whole thing is filled with this tissue over the vessels all around the place. Plus you have retinal edema. These whitish lines are all retinal edema. There's injury to the retina because it's avascular.
So the baby was planned for scatter laser again to the skip areas. So 1 week post scatter laser, there was a partially regressed plus, and regression of new vessels was also seen. But there was a development of tractional fold superior in the superior part of the retina in the right eye. and it was also suspected in the superotemporal area in the left eye. So to rule, so here we can see that in the right eye, in the superior part, whether it was a regressing stage or whether it was a traction, that created a confusion. So similar picture was seen in the left eye, the ridge becoming more clearly well defined with vitreous condensation with the regressing plus disease. So ultrasound was done, and in the right eye, a low reflective membranous echo was noted lying on the retina, but no traction was noted. And in the left eye, similarly, low variable reflective membranous echo was noted, extending till the ONH, but it was not causing any traction to the retina. So the baby, hence the tractional retinal detachment was ruled out, but the baby was still kept in close watch.
So, in this case, you would wonder why we haven't given anti-VEGF injections. That will be the first thing that you will think, right? But you just saw that. That's just the same laser dye. I've just done the photograph after the laser. So we still have to give chance for the laser to have an effect. There is really no TRD. That's why we did the ultrasound. There's no TRD. So we're just waiting for the laser to have an effect, and it will regress. And I see that baby today. All that has gone. The plus is already gone, completely gone. Fibrous tissue is still there on the retina. Today also I did an ultrasound. Retina is well attached. So, and the baby is doing well in the sense baby is gaining weight, becoming healthy. And the left eye also, what you saw, all those things are all disappeared. Now all that tissue is now floating in the vitreous cavity. It is just stretched up. It's like, something has pulled it above. So the whole fibrous tissue is just pulled above the retina. Retina is flat underneath it. Only except for that right eye where you saw that superior thing. It's still not caused a TRD. Okay, and the macula is still not stretched. Macula is absolutely flat. And the eye grows. Okay, remember, the maximum growth of the eye happens in the first month. The neonate grows the fastest, the eyeball grows fastest. So what you see as the macula, small macula, becomes a large macula because it stretches. Okay, so sometimes it's very unusual to see so much of retina is involved in a disease. But when the disease progresses and the eye becomes larger in size, the surface area of the macula is also increasing. So you have to take that in mind. As the child is growing, the macula is also expanding. If you draw a caliper from the upper arcade to the lower arcade, you will see a diameter. This diameter will be actually large. As the first month of the child's life, the eyeball grows. The maximum growth happens in the first 1 month. You've already read, when you make sclerotomies. Okay? A newborn baby, you're almost 0.75. After a month, you've gone up to 1.5. Sclerotomy from the limbus. So you see so much growth happens after a month. The next 6 months, it grows slightly slower. The next 6 to 1 year, again, grows a little bit more. But that's it. That's the fastest growth that you can see. After the eyeball goes slowly. After which you put 2.5, and up to 3, you go up to 2.5. Beyond 3 to 6 years of age, you start making it at 3 o'clock, the sclerotomy. So the eyeball is still growing. But the maximum growth happens in the first 1 month. Okay, neonate. So it looks so funny. It looks so angry looking thing, but you just have to wait. As the eyeball grows, you will see the tissues expand, and your TRD will also separate. The vitreous is condensing, causing contraction, and the tissues will elevate. If there is no actual new vessel disease, it will regress. That's the beauty of ROP. Well-treated ROP, it will definitely involute. You have to have patience. You have to have regular follow-up. That's more important. Don't jump into anti-VEGF. Okay? And this is not aggressive ROP. This is stage 1, 3+. Aggressive ROP, I understand. You can give your anti-VEGFs, you can do laser, everything at one shot.
So coming on to the discussion part, while there are available clear-cut guidelines for staging and treatment of ROP, the response to the treatment, the involution patterns and its clinical implications, and what is the threshold for surgical intervention, it still lies in the gray zone. So here we will be discussing timeline of involution, self and post-treatment, morphological changes during involution and what are its clinical implications, and what is the role of handheld OCT in evaluating the disease. So ROP is a self-limiting condition. It has a clinically predictable time of onset and a definitive end stage when the disease process becomes inactive, regardless of its maximum severity. So when does the involution start? According to the cryo-ROP cooperative groups, the timing of acute ROP events, it correlates best with the post-conceptional maturity. The onset of stage 1 occurs at around post-conceptional age of 34.3 weeks. Pre-threshold disease peaks at 36.1 weeks and the threshold disease at 36.9 weeks, and the involution begins at around 38th week post-menstrual.
So Anjali, what does it teach you?
Whether we intervene or not intervene, the disease will involve.
Forget about intervention. What about screening?
Yeah, the screening
Child
should.
is born at 28 weeks.
Yeah.
So when will you screen?
28 weeks.
8 weeks. 1500 grams. When will you screen?
So within first 2 weeks.
People are going for ROP screening. They should tell us.
32 weeks, sir.
Yeah, around 2 to 3 weeks. Yes. So what is important is the 28 week guideline and the weight. The really low weight and the 28 week guidelines. You see it at an earlier stage. Otherwise, if it was 34 weeks.
34 weeks. Otherwise, within 30 days.
Yeah,
of
within
birth.
30 4 weeks. So why did it came? Because of this. So you might not see ROP, but you might just see an immature retina when you first go screening. So they usually call you after a month if the child's birth weight is beyond 34 weeks. I mean, gestation is beyond 34 weeks. So they will call you. If it is 34 week, then you should go and see. Because that's when you first expect the
Stage
ROP to start. Okay.
So, according to the study by Repka et al. On the involution of retinopathy of prematurity, they found that the acute phase of ROP began to involute at a mean of 38.6 weeks post-menstrual age, and in 90% of the patients, the ROP began to involute before 44 weeks of post-menstrual age. If we talk in terms of chronological age, that corresponded to between 8 to 12 weeks of age. Treatment with laser or anti-VEGF, it alters the course and pattern of involution. So Coates et al. Reported complete involution of neovascularization in threshold ROP in 43 and 73% of the eyes at 2 and 4 weeks following treatment with diode laser. Compared with these findings, M. Isaac et al. Reported involution of neovascularization in more number of eyes after treatment with intravitreal bevacizumab, that is 82 and 100% at 2 and 4 weeks as compared to the laser. So, according to the study of Fleck et al. On time course of ROP, regression and reactivation after treatment, the median time to regression of plus disease stage 3 and aggressive ROP was lesser with the ranibizumab injection as compared to the laser. And incomplete disease regression was more common with the laser after a median interval of around 15 days compared to the ranibizumab groups. And the reactivation of ROP was more common after the ranibizumab injection at an interval of around 53 days compared to the laser. So this meant that the use of ranibizumab injection, it will require a prolonged post-treatment observation to look for reactivation. So what are the morphological changes which we see during the involution in these treated eyes? Hikichi and co-workers, they described there is marked liquefaction of vitreous without a PVD in the laser-treated areas. Faris and co-workers noted that the treated areas had organized cortical vitreous, which was composed of white and grey avascular fibrous tissue post-laser.
So Anjali, how is it different from diabetic disease?
So in diabetes, this vitreous does not organize, it causes traction immediately, but here it does not cause traction.
So in diabetes, how often we see after PRP the PVD has occurred? We see it quite often, right?
Yes, sir.
At least in 30 to 40% patients, and patients complain after you do a good PRP, they lost vision because there is a PVD. Vitreous is disturbed, there is a bleeding, patient doesn't see well. It's a very common thing that we come across.
Yes, sir.
So there is actually hilar detachment in diabetes after extensive PRP, whereas in ROP,
It doesn't
don't have a PVD.
The central portions of the vitreous, they liquefy into lacunae, and the vitreous between these lacunae, they condense into bands and membranes that are well connected to the organized tissue at the vitreous base. The posterior cortical layer of the vitreous remains always attached to this retinal folds, and this form addition is important in the pathogenesis in the treated eyes. So, in the study by Coates MD in ROP involution, factors predisposing to retinal detachment. So, in his study, he noted that ROP fully involuted in approximately 80% of the eyes within 28 days of treatment. He noted vitreous organization post-laser treatment in rest of the eyes, and vitreous organization, which was meeting the study's clinically important definition criteria, was associated with a higher risk of retinal detachments. So when do you call it as a organization? So vitreous organization is considered to be present when white fibrous appearing opacification of the vitreous was seen above the vascular avascular junction. And this organization not always but has a visible connection to the underlying retina, but the bulk of the material, it remains in the vitreous and not on the retina. So they also graded the vitreous organization into 0, 1 and 2, with 0 none visible, minimal grade 1 minimal to mild organization. But the view of the underlying retina is not significantly reduced, and in grade 2 the view of the underlying retina is significantly reduced, and it was considered important if this organization was extending in 2 or more contiguous clock hours. It was grade 2 and it was unassociated with retinal detachment at the time of initial discovery. So the majority of the eyes with clinically important vitreous organization, they developed retinal detachments but several weeks later. So this provided us potential window of opportunity for preemptive intervention.
So Anjali, that child that you just showed, the right eye which we discussed, what kind of, according to the study, what kind of organization was it?
So that was a grade 1.
Could you see the underlying?
Yes, sir, the underlying retina was visible.
At the second photograph, I couldn't see it. That's why I got the ultrasound.
So the vessels were visible under the vitreous, that condensation.
Yeah, it was plus minus. So that's why I have told the parents that there is a possibility that we might have to intervene.
Okay.
Not anti-VEGF, surgery. If I see a traction developing. And how many weeks? They said potentially a few weeks. That's what you said, right? So I've done the maximum laser possible. Plus has regressed. Now the only thing left over is TRD or traction. That cannot be treated with anti-VEGF. It can be treated only with surgery. So that is what we are going to wait and watch. How the vitreous organizes and whether it pulls the retina there, causes traction to the macula. Traction to the periphery, I am not bothered. Traction to macula, I will operate. Lens sparing vitrectomy. Correct?
So in the study, clinically important vitreous hemorrhage post-treatment was also associated with the development of retinal detachments, and vitreous hemorrhage was considered significant if it was severe enough to completely obscure visualization of the underlying retina.
So Anjali, if this patient develops a vitreous hemorrhage, what will you do?
So monitor more closely.
No, you will operate.
Okay.
That is the reason why I said that. Okay. And when the vitreous organizes, it is quite possible that a child is not going to behave, like an adult. It's going to keep doing its baby things. So there can be bleeding from that eye. And if it bleeds, it will cover the macula. Because right under just above the macula. Then we have no other choice, but we have to operate. Simple. Correct? So we don't tell the patient to come after, the child to come after, to be bought after 3-4 weeks. We call them maybe weekly or once in 2 fortnight just to see if everything is all right. If that particular thing has happened, vitreous hemorrhage has happened, then we have to operate. Because that will advance the stage of traction detachment. It will really cause traction. Once the vitreous organizes along the vitreous hemorrhage.
So these are the pictures from this article, with the figure 1 is showing grade 0, no visible organization. The rest of the two showing grade 1, that is mild vitreous organization. Then figure 1D, moderate vitreous organization with the slight obscuration of retinal view underneath. And 1E and 1F, they show the severe vitreous organization. And this with the severe vitreous organization with associated retinal detachment. So the author recommended examination at least bi-weekly during the first 6 weeks after the treatment, with more frequent examination of infants who begin to develop this vitreous organization, or if they continue to have active stage 3 disease or any element of plus disease or both. So coming on to the last part, that is the cicatricial involution. What is the pathophysiology of this? The retina has two vascular developmental processes, that is vasculogenesis and angiogenesis, which is VEGF dependent. So in vasculogenesis, the vessels, they arise de novo from the endothelial precursor cells and they form the major retinal blood vessels. Whereas in angiogenesis, the blood vessels, they originate from the pre-existing vessels and they form the capillary plexus in the deeper and peripheral retina. So inside the uterus, there is low tissue oxygen and the developing retina is in a state of physiological hypoxia. So when a premature birth happens and this premature retina is exposed to the supplemental oxygen, there occurs a phase of vasoobliteration. Hence, the angiogenesis is halted. So as the so this vasoobliteration is followed by a phase of vasoproliferation. So as the retina grows, the oxygen demand increases, but because of the vasoobliteration, the oxygen supply does not happen as much as required. Hence the VEGF load increases and proliferation of the new vessels occurs. So these vasoproliferative cells, they will grow into the vitreous along the collagen fibrils towards the posterior capsule of the lens, and they will extend from ridge to ridge, or from the ridge to ora, and they will contract, resulting in the cicatricial changes which we see in the stage 5 of the ROP. So what is the surgical outcomes in this cicatricial involution, whether we should touch or not touch? That is questionable. Anatomical success is defined as the attachment of posterior pole at last follow-up. So the successful outcome for stage 4 and stage 5 ROP after vitrectomy with 20 gauge have been between 62 to 90%, 92% and 13 to 42% respectively. With 25 gauge vitrectomy, the outcomes increase to 81 to 100% for stage 4 and 13 to 45.5% for stage 5. So there are various factors which affect our surgical outcome. That is, what is the stage of the disease, then what is the configuration of retinal detachment, whether it's open or narrow, whether the plus disease or active neovascularization was present at the time of surgery, and also what is the age of the baby at during the surgery. So Makimer et al. And Cusick et al. They reported that a higher success is obtained if we operate the babies after the age of 6 months. Gopal et al. Suggested that the disease is more vascularly active in babies less than 6 months of age. So operating within 6 months has a marked risk of post-op hemorrhages. And Fucino et al. And Hirose et al. They reported better visual outcomes in these children if they are operated before 1 year of age. What are the functional outcomes? So even though the anatomical outcomes have been reported up to 50% success rate, functional improvement in these eyes is not significant because of the degenerative changes in the detached retina. And even if detached, it remains thin. Gopal et al. Reported mobile vision in only 2 out of the 96 eyes studied. So when to operate, wait till 6 months or between 6 months to 1 year was a question. Waiting too long can increase the degenerative changes, and operating earlier can cause that bleeding post-operatively. So this is again question open for discussion. So coming on to the last part, that is what is the role of handheld spectral domain OCT in ROP.
So that question was when we didn't have any anti-VEGF injections. Okay, both studies are pretty old. So now we don't wait for 6 months and plus to operate. If we see a new vessel disease cicatricial stage happening, we see some new vessels there, leftover new vessels, we'll give anti-VEGF and do the surgery. We don't really wait for all that time. A disease is cicatricial. There's more fibrous tissue. So fibrous tissue dissection is easier than new vessel disease dissection. So once you give anti-VEGF, you're able to manage. As long as you see white tissue there. You see a white tissue, operate.
Yes.
You don't wait for 6 months.
6 months or 1 year.
That can be also considered because some of the babies may not be systemically stable at that point of time. Maybe at the 6 month point timeline, they are probably healthier, they have more weight, and they can tolerate gel anesthesia better. So maybe that's also a reason why that 6 month timeline seems to be a reasonable time to operate those babies. But in general, 6 months to 1 year. That's it. Beyond 1 year, it really doesn't. Even if you see a stage 5 ROP, you can operate. There's no doubt about it. But the retina is so degenerated that you will get nothing out of it. The child is probably having zero outcome, visual outcome.
So the role of handheld SDOCT in ROP. So in a study by Chawla MD et al. In insights into advanced ROP using handheld SDOCT, they found they could pick up retinoschisis, retinal detachments, and pre-retinal fibrovascular tissue, which were not visible in their conventional clinical examination. And in the study by Alex T. et al. On vitreous findings by handheld SDOCT, they predicted the presence and the severity of ROP based on the vitreous opacities and the tractional vitreous bands seen in the SDOCT. So this novel imaging modality, it can reveal the location and extent of the posterior ROP pathology, which sometimes not evident on standard examination. Overlying vitreoretinal interface changes can also be appreciated better than the routine clinical examination. This could affect future clinical decision making if studies which validate the management strategy based on findings from these imaging techniques are available. So the take-home message is ROP, it's a self-involuting disease peaking around 38 weeks of post-menstrual age. Laser treatment will cause morphological changes in the vitreous. Thus, a close watch post-treatment is important. Not all peripheral vitreous condensations are tractions, but keeping a close eye on the severity is important. Handheld SDOCT is the future. They can alter our course of management. So now some few clinical slides I'll show.
Yeah, so you can see the actual effect of laser. So this is a laser before laser. You can see the ridge, you can see foveal hemorrhages, retinal hemorrhages. And from here, it goes to this. So you can see how fast the whole thing regresses. There's nothing left. The tissues are involuted. That's the magic of laser. And this is a foveal hemorrhage there. So we just got a OCT which shows us the hyperreflectivity, vertical hyperreflectivity at the fovea because of this hemorrhage. Not a good sign. It's a poor prognostic indicator for vision. That's the OCT shows you a flat retinal contour. Go to the next slide. So here you can see this is the white tissue elevated, and the retina vessels go beyond it. Tissue is above it. So you can actually see vessels, normal vessels go beyond it. Go to the next. So this is how it was before the laser. And then you can start seeing how nice as well. You see vessels beyond it. Then the vessels are remodeled. Here's a ridge. When the ridge disappears, you can start seeing the normal dichotomous branching of the vessels. And they'll go proceed over the laser scars. So you should look for that. The vessels crossing the laser scars. These vessels are in the inner retina, laser scars in the outer retina. So vessels, the inner vessels are going to cross the laser scars. unless in extreme periphery where the retina is totally destroyed because of laser, you probably not see any vasculature. So if you do an FFA, you probably not see any vessels there because you completely destroyed that retina. There's no retina and no vasculature.
So the various observation only points to note after treatment is whether there is reduction of the ridge vessels, whether retinal vessels are crossing the ridge and progressing anteriorly, whether there is vitreous opacification or condensation over the ridge. We may see new vessels elevated over the retinal surface, but that is part of regression. These vessels will be eventually replaced by vitreous strands.
Yeah, so this is a tractional schisis. If you see very carefully, those are a two-dimensional picture. You can actually see the vessels are actually elevated, but it's not TRD. Okay. So if you clinically examine and clinically stage the disease, you'll say it's stage 4A. It's still not involved the macula. All right. Go to the next slide. Back, further back. You've gone too far ahead. So when you do an OCT, you see there's this tractional tissue over the retinal surface, and then you have tractional schisis and RD. The shallow RD is there behind this whole thing. So this is where we did a buccal, if it is zone 2 and anterior, or you do vitrectomy to release that traction. Okay. Your jumping slides. Yeah, so you do an encephalage. So this case, you see the RD is extending posteriorly. The fovea probably is spared. It's going all the way here. So here you can choose to do encephalage if it works because the fovea is still attached. Or you go for lens sparing vitrectomy because it's 4B. 4B means macula is detached. So this is already gone into a cicatricial phase. Okay, so this is actually a regressed ROP. So this is a white fibrous tissue. You see the falciform fold and the dragging of the macula and the disc tissue. So you can see the retina, which is here. This is the fold, and this is the retina. This part of the retina. It's totally disorganized. There is no photoreceptor line at all. It's just a flat tissue there. It's above it. There again, there is disorganization retina. And this is the tissue exactly at this level. So you can see there's really no tissue there. There's no layers. There's no organization of the retina. So whatever you do, this child will not see well. There's no photoreceptor. But if you attach it, anything which is left over, photoreceptor, you never know. Child will probably be seeing through other areas, the areas which have still got some attachment. So we did surgery for this, I think. This is aggressive ROP. See, you don't see anything. You just see little few vessels around it. This is actually the disc area. See the fibrous tissue or the condensation is going all the way anteriorly. It will go all the way anteriorly to the lens. This is something where you will treat with anti-VEGF and then you will do a lot of laser. Then ultimately you have to do surgery. You can see the tractional lines. Because the retina is being pulled so much, the RP, which is one of the first cells to get developed and the eyeball is formed. So it shows that the traction is slowly developing as the eyes developing. So this RP you can see undergoes hyperplasia and you have really thick lines. So this shows that there's so much traction in this eye already. Rapid evolution of a disease. That is aggressive ROP. The traction has also started developing. And there are retinal folds. So then you give anti-VEGF, do laser to avascular retina, then you do lens sparing vitrectomy. So I was wrong. If the vitreous opacification does not reach the lens, then you do lens sparing vitrectomy. So if it doesn't reach the lens, I'm talking about that. So then we got the retina back to its position. You can at least see the disc now. Okay, this is the anterior hyaloid, which is organized. So this portion that you see is what you see in PHPV, the attachment of the central hyaloid stalk to the anterior hyaloid right behind the lens. So these remnants are seen. Okay. And then the other eye had very bad disease, so and it was almost touching the lens. The hyaloid fibrosis is already touching the lens, so we had to do lens sparing lensective vitrectomy. And you can see the end result. Those traction lines are there. All these are all old traction lines. And look at the retina. This is the only viable retina, and that is inside the fold. A non-viable retina is all around. Child is going to have no vision. That's aggressive ROP.
Thank you.
Case 2 and 3, how closely you followed up, sir? You call that every week, sir?
You could ask Zubin, when he was doing laser, the child became blue. In front of us, pink lips to purple lips. We really had to send the child back. And the very night they got admitted in child's trust, because the child probably had some sepsis going on. We didn't realize. And for a week they were there in child's trust. They got so that worsened the disease actually. So if you have a septicemia, ongoing septicemia, or some need for intubation in a young child who already got an ROP so aggressive, it worsens. That's the problem. But if you, an indirect measure of things settling down is you keep asking the parents that the child is it feeding well, sleeping well, growing well, has there been a weight gain? That is an indirect clue that the child is doing well, and maybe your ROP will regress better with lesser treatment sessions. It's not that because the child is doing well, systemically you don't treat the eye. No, that's not the case. What I'm trying to say, lesser treatment sessions, lesser need for aggressive laser, lesser need for injection, because it might regress, involute. So involution depends a lot on this baby's systemic factors. Baby is sick in the ICU under intubation, it is not going to do well. You may end up having to give anti-VEGF injections regularly.
After giving the injection for a aggressive ROP, how do you follow up the baby? How frequently you follow up, and what are the things you see in the eye, and what makes you to take a decision when to follow up? Can somebody give a little clear view, simple? After hearing all the natural history of how does the ROP behave.
So the anti-VEGF will start working in 1 to 3 days.
Okay.
And we need to see for the signs of regression, like the tortuosity of the vessel should decrease. Sorry, the dilatation of the vessel will first decrease and followed by media clarity will increase, and we need to follow up like in a week span, 3 days and then in a week, and might think of doing laser once the media clarity increases. Also, the if we can come and see the tortuosity and the dilatation of the vessel. If it decreases, then eventually it might require laser.
So 1 week later you see. You also see for the pupillary dilatation also well. Okay, so once a week later you see, and then what happens next? What do you see in that week? So next week you see, right? So at that time? No, when you see, you are curious to see something which makes you to take a decision. What are the things you see again?
Is the traction has increased? Is it pulling the retina? Then we need to go for surgery. And if not, then laser to the peripheral vascular.
But you had planned third day, you had planned that by next 1 week I would be planning some laser. That's what you planned, right? So for the laser to see that the environment is good for laser, what are the things you see in that eye? Traction is next level. So in 1 week, traction may come or may not. But your decision was like third day, you wanted to treat with a laser. So what environment you see in the eye when you want to decide the laser? Tortuosity would have come down, pupillary dilatation would have come, increased. Then vessels, anything you see in the vessels, you're seeing here. Showed the very good photos, no?
So, along with pupillary dilatation is a good sign that the baby is improving. Also, the growth of the vessel will trace what was the zone that we have marked in that third day visit.
Exactly.
Now
that's what
it
I
has
wanted
grown.
to ask him. So you need to just put a little landmark or some drawing you need to make it in every clock hours for that to come. So whether that vessel has grown or not. So how do you know? You can't remember all those things, right? So a serial drawing or whatever, if you have a good photography, that's a different issue. If you don't have at least a good schematic drawing, in each quadrant you can make. Okay, so the vessels grow in that quadrant.
Yes, sir. So we'll follow that baby weekly for the growth of vessel afterwards. If it is a persistent avascular retina, then we'll take the decision for going ahead with laser.
Okay, no, so that 1 week follow-up, you saw some vessels are growing, the pupil dilatation. So
Yes, sir.
would you like to do any laser at that time?
So if it is growing and looping and all, we are not seeing abrupt ending, then we can follow up.
You can follow it up. Okay, next follow-up will be?
Next follow-up week, sir.
So you would not like to miss the weekly follow-up at least for certain weeks.
Yes, sir.
Till you feel that okay, the things are under your control.
Yes, sir.
Okay. So then when do you make the things that okay, I need a laser here? Or no traction is going on? At what period?
So sometime if it is abruptly ending, or we are seeing the looping, or one small pre-retinal heme, areas of pre-retinal heme, or new vascularization, these are the signs that we'll decide for going ahead with laser.
With the natural, that involutional, she was giving a rough history, a timeline like what happens. So usually these things happen at what period?
Sir, I think 36 to 40 weeks is the time.
Little more later, right? 36-40 weeks is the second or third week what you are seeing, the vessels are going and all those things, what you told, the good things will happen in that time.
Yes, sir.
Because you have given an injection. So the sudden altered changes with the injections you are looking for, correct?
Yes, sir.
So good things you are not worried much about. You are worried more about the bad things of the injection.
Yes, sir.
Okay, that happens during at least maybe a month or two after weekly follow-ups.
Okay, sir.
Okay. And what is that thing which makes you feel that injection is not doing good? What finding? What do you see in the eye?
Worsening of tractions.
traction might worsen.
Traction may worsen. Okay.
So persistence of plus disease, because plus disease is the first to respond after.
Persistence, you want to call it as persistence. He has told that, okay, things are all going good, no? After the injection. Sudden again flaring up of the things which was going down. Right? All the things again will start. You had given the good timeline, right?
Yes.
To be followed. So again the vessels start becoming angry. So angry means what? You won't see angry vessels means what? Dilatation, yeah. More dilatation.
Again, new vessels, we start seeing proliferating new vessels at the vascular junction. So then we can suspect it is reactivating. So we'll need to treat it.
So even a one quadrant or one clock hours of such things happening is a reason or indication for what?
Go
Treat.
ahead to treat, yes, sir.
How do you treat? One more injection.
Laser we can plan, sir.
Laser we plan. So where are the laser done? Only in that quadrant or are the other quadrant also?
So, better to cover the avascular retina
Why?
entirely.
Why? Because the unpredictable
It can
nature of
develop anywhere else.
the anti-VEGF.
Yes, sir.
One good thing is that if you want to retreat, and especially in reactivation, you can try FFA first and treat exactly the areas where you can see there's avascularity. So in babies, we can do FFA and treat accordingly. This is especially true in the anti-VEGF era. You can do FFA and you look at the areas. And if you don't have an FFA, and you treat all the skip areas, you can even treat the vessels directly. There's no harm in that.
Sir, I have a question.
Because the vessels are actually on the retinal surface. They're not really elevated in the vitreous cavity. Yeah, you're saying something?
Yes, sir. Sir, I have a question that suppose, like, sir told the scenario, like after injection, everything is going good, like the disease is started to regress. Do we start doing the laser from the anterior part, like?
Beyond wherever you have last seen the ridge.
We've given one injection. We follow up 1 week later. We see that the disease has reduced. So do we plan laser, like we can plan laser from one setting of laser from the anterior?
Avoid the possibility of a reactivation. Okay, so either you keep following the baby every week, say for another 3 months, which is kind of impractical for the parents. Okay, or you do laser. So that's what I'm saying. So then you don't wait for the reactivation. You see vascularization has stopped after some time, and there's nothing going on beyond that. You do finish off the laser beyond that. So that question of that reactivation happening will not be there because you are treating the avascular retina, and you are able to stage the intervals, the examination intervals a little longer. Otherwise, if you are treating purely with anti-VEGF, okay, and waiting, first indication is the plus has reduced. New vessels have regressed. Next thing that should happen is if the new vessels regressed, plus is reduced, vessels should go beyond that area which was previously avascular. So that area is now getting vascularized. Okay, so that is a good thing that is happening. Now, what we have seen is, despite this new vessels and the normal vasculature going beyond that ridge where the new vessels were there before, and vascularizing the retina anteriorly, people have seen reactivation at the previous ridges. Okay, you get my point? You may have seen vessels growing beyond the ridge anteriorly, maybe into zone 3, but reactivation can occur in the area which was showing the new vessel disease previously, before injection. So that is the problem with anti-VEGF. So you can see reactivation not at the anterior parts, you can see reactivation even within the vascularized area. That is the problem with that ridge. So-called ridge may have become flat. Reactivation can occur within that area only. So that is a problem with anti-VEGF. That's why you have to keep seeing the babies, and then they depend on FFA to treat those reactivation areas. Because now it's a new vessel disease within an area, also normal vessels happening all around the place. What will you treat? So then you have to do an FFA, see where is the new non-perfusion area. You may see vessels, large vessels, but it doesn't mean that it has got angiogenesis, meaning capillaries have developed. Only if a normal capillary develops, the retinal angiogenesis is complete. You may have the large vessels, but you may not have the capillary bed within that retina. So that is the problem. So if there's capillaries have not developed in the retina, you may be fooled to think that that is vascularized. Okay, we are safe now. But that's not the truth. That is, I'm talking about only those cases where you are treated with only anti-VEGF. Right? So don't be in the impression that anti-VEGF, if you see vessels beyond that ridge is going all the way anteriorly, the reactivation will not occur. Reactivation can still occur in the area which was previously having a new vessel disease, the ridge.
Suppose it is zone 1 you have injected and it is not growing, the macula is not getting vascularized, then you might think of not lasering that area, do only the anterior laser and wait. Okay,
Yes, sir.
you can do that.
The question was good because when the cases which was not given injection or maybe before the era of the injections, that's what we used to follow. We started the laser maybe from the periphery and reach short of the ridge and the vascular zone, expecting that the next few days some of the vessels will still more grow further and you can save some more retina. That was the concept of the pre-injection or the cases where you don't give the injection. With the injection, the whole natural history has gone for a toss. Okay, so that's how then the utility of the angiogram and all comes. Same thing, the same question what I wanted to ask is, you see the baby, now you are following up, everything is good. The vessels have gone and stopped in somewhere in between the zone 2, 3, somewhere. Vessels are not dilated, it's not tortuous. The baby is growing 3rd month, 4th month. You keep seeing. Your follow-up frequency reduces from weekly to fortnight or a monthly. Then what you are going to do? If the vessels are there, stop, but it's not going further, you don't feel that it's normal. It's an injection given eye. So then what will be the plan?
We need to treat with laser.
So how long
least-
then you would have waited for me to tell this? Means?
So, around gestational age of 45 to 50 weeks overall total. That is when we finally decide if it's not growing beyond a
Beyond
certain
that, you do the
area, we
laser.
need to laser it.
Okay, the child would have grown by 3rd or 4th month by that time? It would have been 3rd month, 4th month. Correct. So we'll be able to do the laser with that big baby. Okay, so that's where the challenge comes. You know things are all there. You know that the injection is not giving the thing and you're scary. You want to treat, but you don't want, the vessels are not showing that it needs treatment. The child is also growing. That's where the challenge comes, when to take a decision to do the laser. So in case if such areas are little large enough and you feel that, okay, this is not right way to stop, wait for further, or just leave it like that, okay, that those areas doesn't matter, prefer to do the laser, and so that you can also sleep and the eye is also safe. Because once it crosses, again this issue of GA comes. You'll not be able to do the laser with a topical after 3 to 4 months. It will be very, very aggressive, active. So
Sir, one baby I saw, we were following weekly for the growth of the vessel, but the cornea was very hazy. So, just for the sake that we might not lose the view of the fundus, prophylactically we did laser in that case also.
Perfectly. Okay. But what was the reason for cornea haze?
Sir, we have sent our cornea specialist from here also to have a look. They said that sometimes premature babies can have a little corneal haze.
How long it will stay?
Sir, the baby was
No. How long the corneal haze stays? Why the corneal haze? It's a part of prematurity they do.
Yes,
But
sir.
how long it will stay? Is it a permanent one?
Sir, no, it was abnormal for that, unusual for that baby. It stayed little longer, but with the laser, we noticed that the haze was better. The corneal haze improved, but it was longer for that baby, sir. What was the week of that baby? I don't remember, sir.
Don't use gestational age just like that. So you should use post-menstrual age. Post-menstrual age is gestational age plus chronological age. Okay, child is 3 months old plus gestational age of 28 becomes 40 weeks. Correct? If you use that terminology, because that is where the timeline starts for ROP. So if you use a PMA as a guideline, as a start from 0, then you can actually. So you have to make it standardized. No, you can't just say everything gestational age. This is chronological age. Right? People will get confused when to do what. So using the PMA as a guideline, that this is at 42 weeks, 43 weeks, we'll be observing the child. That's the last, because the child has already grown so big that you can't treat them with the topical anesthesia. We can't wait for the vessels to grow further or show a change. We'll treat off. So we, in our dictionary, there's nothing called persistent avascular retina for us. We treat off everything. After say 42 weeks, child has grown well. Beyond that, we don't wait. If there's nothing, no action happening beyond the ridge, zone 3, zone anterior, zone 2, we'll just blast it off. The child has got most of its central retina well developed. So you can do the laser. Beyond that, no GA. Not for laser, at least. As he said, you will sleep, baby will sleep, parents will be happy. So don't wait beyond 42 weeks. So keep that in mind always. Always, I think, good idea to keep writing every time you write notes. Write PMA. Child is PMA this week, now, this visit. Child is this switch. So that gives you an idea, your timeline. When is there? Because everything is described like that. The ROP starts at around 34 weeks. Plus can start at 36 weeks. So everything is given on that timeline. So you know. So when we see a child at 37 weeks, already mentally we have decided this child will have maybe having ROP now. If I'm going and seeing a child at 32 weeks, I'll say there's no ROP. I'm sure that there's no ROP. If the child's systemic condition is good, I'll say it's probably immature right now. So already anticipated the problem. But if I know that child has been intubated, is suffering from a lot of disease like intraventricular hemorrhage, seizures, repeated blood transfusions, septicemia, I know this child, even at 32 weeks, will have bad ROP. Could have aggressive ROP. So keep all that in mind. That's the timeline. And when it is ROP, you take the decision for treatment. Don't depend on pediatrician. No, child is not well, not okay. So you make the child well, we'll do it. We'll do it. We'll do the treatment. Okay? Because if you lose that time, you'll never come back. Because the child is being treated systemically, maybe undergoing a lot of treatment. You sit with your pediatrician or your neonatologist and decide, I have to treat the child. You tell me the window when I should treat. You make the child stabilized, I'll come and treat. Whether it's anti-VEGF or laser. But don't sit and wait for the child to get better systemically. You'll lose that 100%. Because that's the most common thing happening. All the children who come to us now, they are mostly taken care of because of the systemic disease and nobody's seen their eye. And we end up with a stage 5 ROP, so difficult to treat.